Hi, everyone. We just wanted to start off by giving a big thank you to Dr. Njoo for taking the time out of his understandably very busy schedule to provide us with this session. We all really appreciate it. Also, big thank you to Ontario medical students for signing up. We currently have 173 attendees tuning into this session. And a special shout out to Western, who had by far the most registrants. Just to introduce ourselves quickly, I'm Sophie, and Dave is also one of the other panelists for this session, and we'll both be moderating. We are both second-year medical students at U Ottawa and co-presidents for the MD2022 cohort. In terms of the structure of the session, we will start off by providing a quick overview of Dr. Njoo's background, which will be followed by the question period. We have compiled a list of questions, and a big thank you to Yipeng Ji, a U Ottawa MD 2020 student and incoming public health and preventive medicine resident at U Ottawa, for helping us sort and compile these questions. Dave will be asking Dr. Njoo the questions, and as you may have noticed, attendees cannot turn on their webcams and microphones, but you can ask your follow-up questions through the Q&A section. And a special note here that there are multiple buttons on Zoom. It can be a little bit confusing, but just make sure that if you're asking questions to use the Q&A button specifically and not the chat, but we'll remind you of that throughout the session since I'll be moderating the questions that will be asked. Also, another tip is that you can use the upvote button on other students' questions, which we do encourage since if you have similar questions, as we do have limited time, and it'll help us establish a priority list. And just a note that this session is being recorded so that it can be shared with medical students later via the Aesculapian Society's YouTube channel, which is our medical student society for the University of Ottawa, Faculty of Medicine, and the program. And now to start the session, we're going to present Dr. Njoo his quick overview of his very impressive background. So Dr. Njoo completed medical school at the University of Toronto. He then completed residency in community medicine, now known as public health and preventive medicine, as well as a master's in health sciences, both at the University of Toronto. Currently, Dr. Njoo is the Deputy Chief Public Health Officer and Chief Medical Advisor to the Infectious Disease Prevention and Control Branch of the Public Health Agency of Canada. And he's also an adjunct faculty member of the School of Epidemiology and Public Health of the University of Ottawa. Dr. Njoo has been very involved in Canada's response to the COVID-19 pandemic, and you may have seen him during the COVID-19 press conferences. We are very grateful to have been able to organize this session with him. And on that note, if you don't have anything to add, Dr. Njoo, we can move on to the Q&A portion, or if you wanted to introduce yourself.
Sure. Well, thank you very much, Sophie, you and David, for organizing this. For myself, it's always a pleasure to speak to medical students. I'm sort of way past medical school, sort of getting towards, I would say, the downslope of my career. But I like to say, I'm very pleased to be able to share my experience with all of the students out there, and hopefully, you know, in a small way, maybe even do a bit of a recruitment. So maybe before we get to the questions, what I might do, because I looked at some of the questions that were submitted, is give a bit of sort of the history of what led me to my current position in terms of my career path, and that might be, I think, informative, hopefully interesting to all of the students out there in terms of how did I get into public health, and you know, why did I end up here? So really, I think, like I'm not sure, like many of you, I certainly didn't enter medical school to be, quote, become a public health physician. To be honest, I thought that, okay, I'll probably end up being a surgeon. That's what I thought I'd want to do. And so I went to med school, and you know, I'll be quite honest, I think maybe skipped a few of the public health lectures. I don't know what the heck, it's not really for me. But I think to me, my epiphany, and this is just a personal, is that I think it was probably my respirology rotation. I think doing the usual rounds in the hospital with the staff person, staff men, and I think we're looking at some patients, you know, COPD and so on, and also people with lung cancer, etc. And you know, the attending was talking about a certain patient and saying, okay, you know, Mr. So-and-so is now scheduled for a bit of a surgical resection tomorrow, and we're going to try the latest chemotherapy regimen, et cetera, and so on, et cetera, for his lung cancer. And I just, you know, I thought to myself, wow, you know, that's interesting. You know, we could experiment or do something that might obviously, hopefully help this individual out. But we all know what the cause of lung cancer is, and it's smoking. And so I started thinking to myself in terms of, you know, by the time we see a lot of patients in our practice, or when we're out doing clinical work, it's really sort of at the end of the sort of their path in terms of what they've been exposed to, whatever maybe environmental influences, et cetera, affected their health. And we know that a lot of stuff is upstream and maybe not even related to, quote, clinical care. So obviously with the tobacco issue, et cetera, being, I think, a first passion of mine, that maybe start thinking about, okay, is there something more that I could be doing as an individual rather than just being, quote, an individual clinician? So that was my first sort of interest in public health. And then I guess part of it's also, I think, maybe your cultural or social influences, your family background, et cetera. Certainly with my parents' background and so on, I was always interested in terms of international health, the interplay between different cultures, different ways of thinking, learning, and so on. And so that, I think, also led me to consider a career in public health. And so the rest is history. I went into the residency. My first sort of papers and so on are all about the tobacco issue, the politics of tobacco, and so on. And quite interesting because my first job afterwards was with the City of Toronto Health Department as the one of the associate medical officers of health. And back in the day, so I'm dating myself, the big issue then was basically the first foray in terms of legislation and bylaws to regulate smoking in sort of in municipalities where, you know, way back when, probably you folks wouldn't even know that, you know, smoking was allowed everywhere, you know, even on airplanes and in restaurants, et cetera, and so on. And so to me, it was a tough fight, but certainly little by little, we brought in various bylaws. I think obviously based on the evidence, I think in large part because of the effects of secondhand smoke. And so that whole balance between individual rights and quote societal rights to good health came into play. And the rest is history. So I worked at the City of Toronto and then at the provincial level, got to do a lot of interesting things. For example, I was one of the people looking at the economic analyses, looking at cost benefit analysis in terms of a more universal hepatitis B vaccination program, which I think many of us also now take for granted. So that shows, I think, in some ways how, as a public health physician, you can actually maybe not, personally all by yourself, but be part of a system that might actually influence the health of a greater number of people than you might be able to do as an individual, let's say, family practitioner in a practice with 4,000 or 5,000 patients. So I don't regret the choice I made, and certainly going up to the federal or national level, I've had some great opportunities working with great international colleagues at the World Health Organization, CDC in the US, et cetera, dealing with global issues as well, tuberculosis, HIV, and so on. So that in a nutshell, I think is a bit of my career path, and hopefully as we go to Q's and A's, some of that sort of background will sort of resonate as we go through hopefully a very interesting session in terms of what you folks would like to know. Thank you.
Thank you, Dr. Njoo, and that's certainly some impressive and great examples of the work of public health, especially outside the pandemic as you were developing your career. A lot of us, of course, would love to know. We see you on TV and we know that you have an important role, but what is exactly your role in Canada's response to COVID-19?
Okay, so not to give a whole lecture about the way government works in Canada, what I would say is that we work in what we call a federal system of governance. So that means that there is a division of what we call powers or responsibilities between the federal government and the provinces and territories. And so to cut to the chase, what I will say is that the provinces and territories, as you probably well know, are responsible for the delivery of both public health and healthcare services on the ground for their respective populations. And so what the federal government does is that in many ways we are sort of the facilitator, the convener, to actually, quote, bring the provinces and territories together so that at the end of the day, hopefully, whatever we do across Canada is coherent, so that even in terms of, say, healthcare, that someone in British Columbia, if they go to Prince Edward Island and they, have an accident or so on and need to, get some healthcare, there really should be a sort of seamless to them, that it shouldn't be a problem of whether you're a resident of British Columbia and what they actually do and get and receive in terms of healthcare services in Prince Edward Island. So that's one part. But from a public health perspective, what we do is that we actually have various committees. I'm actually the co-chair of something called the Communicable and Infectious Disease Steering Committee, which is what we call a nice acronym, an FPT committee, or Federal, Provincial, Territorial. My co-chair actually is in normal times, and you might have seen him, especially if you're in Quebec, Dr. Horacio Arruda, who is sort of the chief medical officer of health, you can call it, in Quebec. And we actually meet with representatives from each of the provinces and territories so that we develop guidelines and so on in terms of, how do we diagnose or treat Lyme disease versus, antimicrobial resistance and so on and so forth. So that's it in general. And so I would say that here for COVID-19, Dr. Tam and myself are sort of the lead technical experts, I would say, for the federal government's response or responsibility for COVID-19. So if you were looking at it in terms of different levels, we obviously are sort of the point people, if you can call it, in terms of any international connection. So with the World Health Organization, CDC Atlanta, I've had lots of conversations with counterparts in the US, exchanging best practices, tracking the epidemiology worldwide, what we could or should be doing in terms of research for vaccines and so on and so forth. At the international level, we would be sort of the lead technical sort of points of contact. So then within that sort of the federal level, we're also the contact point in terms of working across all of the various federal departments. You can imagine a whole bunch of federal departments from research to procurement. It goes on and on, even our regulatory colleagues at Health Canada. We actually connect with them, making sure that as a federal family, if you can call it that, everything we do is sort of connected within, as they say, the federal space. And then obviously, as you probably hear sometimes at our press conferences, we're also part of this new special advisory committee or council dealing with COVID-19. And so we have regular meetings with our quote counterparts, many of them also quite well known now because of their media appearances, the other chief medical officers of health, such as Dr. Bonnie Henry in British Columbia, Dr. Dina Hinshaw in Alberta, and so on and so forth. Obviously, Dr. Arruda in Quebec, and also Dr. David Williams and Dr. Barbara Yaffe in Ontario, who are also are old colleagues of mine in another time and place. We meet, we discuss issues, even issues that are how I would say moving along now in terms of where we were back then, where we are now in terms of what we might call facial coverings or the use of non-medical masks in public. That has also evolved over time based on the sort of the growing body of evidence and so on and so forth. So we might get into those types of questions as well. So hopefully that in a nutshell gives you an idea of what we do and how it works in both the various connections internationally all the way down to provinces and territories.
Definitely, thank you. That was an excellent overview. And we actually had our first question posed into the Q&A of the day. And so the question is, what determines whether or not each public health unit has a long-term care outbreak management team or not? So why would some units have such teams and others not have them?
That's difficult for me to comment. I'm obviously, as you say, in the federal space. I used to work on the provincial side of the fence. And I will always say that it's one thing to be at the federal level, and I certainly would never comment on what happens at local level unless you've actually been there and know what's actually happening on the ground. So what I will say is that having now been at the federal government level for some time, I do recognize that there's different systems in place in each of the provinces and territories in terms of how both public health and healthcare is delivered. So I will say that some provinces probably have what I would call a more centralized system in terms of both public health and, I'm not sure, healthcare, and others are more decentralized. And I would say probably from my experience, probably one of the most decentralized, if not the most decentralized province in terms of healthcare delivery is the province of Ontario, in which all of us, I guess, US students are now studying in that system. And so if you've had any experience or placements in, quote, local health units, you'll know there's quite a number in Ontario, and that really is different compared to, let's say, another province like Alberta or British Columbia, where it's much more centralized. So I think that might explain where the question is coming from, why there might be a difference between what is done in one health unit versus another. All I will say is at the end of the day, it's always, I think, dependent on local context. So I would say that, local officials, based on the structure, knowing the community, sort of the system, the healthcare facilities, long-term care facilities as well, they're in the best position to determine how best to deal with there are various stakeholders, if I can call it that, both in peacetime, if everything's going well, to hopefully have those good relationships established. And then unfortunately, if there is an outbreak and so on, how best to manage it, as you say, maybe with a specific outbreak team, or maybe there might be another structure in place. So that's all I can say, recognizing that there are differing systems, both sort of within a province, but also between provinces.
Thank you, Dr. Njoo. And of course, moving on to the topic, as you have certainly mentioned, is very much on people's minds, COVID-19. And just to start us off for all the medical students, some information from the Harvard COVID curriculum. COVID-19 or SARS-CoV-2 is a coronavirus. It's a positive sense single-stranded enveloped RNA virus with helical capsid. It enters host cells through interacting with ACE2, an interferon-induced gene expressed on type 2 pneumocytes, intestinal epithelial cells, nasal goblet secretory cells, olfactory epithelial support cells and stem cells, and nasal respiratory epithelium. And some information from the World Health Organization: this new virus and disease were unknown before the outbreak began in Wuhan, China in December of 2019. We know that people can catch COVID-19 from others who have the virus. It spreads primarily from person to person through small droplets from the nose or mouth, which are expelled when a person with COVID-19 coughs, sneezes, or speaks. The droplets are relatively heavy, do not travel far, and quickly sink to the ground. People can catch COVID-19 if they breathe in these droplets from a person infected with the virus. And they can also land on objects and surfaces around the person, such as tables, doorknobs, and handrails. And people can become infected by touching these objects or surfaces, then touching their eyes, nose, or mouth. With some of that background information out of the way, and so that you don't get too many questions on those nature, Dr. Njoo, in terms of disease control, what is the current situation in Canada regarding COVID-19, and have we passed the peak?
Okay, good question. You can see we put the data on a sort of a daily basis on our website. So before I actually get into the actual what the data is, one of the things that I've acknowledged in our press conferences as well is that our system in terms of surveillance and reporting in Canada isn't perfect. I think even in the best of times, I think people will always recognize that there is, quote, an underestimate for quote, reporting of most infectious diseases, because in terms of who gets tested, who has a laboratory confirmation, how those reports get rolled up and sort of, put up to the various levels from local level to provincial and then to national level. There's always, I think, room for improvement. And so the case counts we get at the national level are really based primarily what we call lab confirmed cases. And one of the issues right now is, I guess, the testing capacity, or maybe, some gaps, you might call it, that some local jurisdictions may be having in terms of, I quote, accessibility to testing by people who might actually need the laboratory test. I think the best example, I might use the province of Quebec. It's one thing to say, okay, we could or should be testing anyone who's symptomatic or a contact of a case and is also symptomatic. But for many populations that they're hard to reach. For example, I know in Montreal, in North Montreal, there are issues in terms of having people being able to avail themselves of the test. And so they're looking at different approaches, such as having sort of more mobile sites, vans and so on, going out there to the community so that people can get the test. So that's, I think, sort of a long way of saying that, yeah, even though we have case counts and so on, we know that it's not something that's perfect, and it's something we could be doing better. So having said that, right now in Canada, every day we're increasing sort of the case counts. We're now over, I think, 71,000. And unfortunately, it also includes over 5,100 deaths. So I would say that overall, deaths may be actually a better indicator, because that's sort of the final sort of, unfortunately, outcome, potential outcome. And that obviously could be better, would be better tracked to just quote lab confirmation of all cases, especially the ones which might only be mildly symptomatic. The good news is that if you look at some of our presentations in terms of modeling and so on, and just what we're getting in terms of case reports, one of the things we look at is doubling time. For example, how many days does it take to double from 100 cases to 200 and so on and so forth? And so at one point, I think several weeks ago, unfortunately, the doubling time overall for Canada was in the neighborhood of about 3 days. So that's kind of scary, thinking every 3 days, the case counts where we're doubling. Right now, we're in a place where the doubling time is more in the order of about 20 days. So that's quite an improvement. And I think it shows that all of the sort of physical distancing measures, as well as obviously people hopefully taking to heart all of the education about frequent hand washing, staying, staying separate from others if you're sick, coughing into your sleeve, all those good things that people could or should be doing are being actually done. And so I would say that at this point, we're starting to at least flatten the curve. The question about whether we've reached a peak or not, that is always one of those things that you can only really be able to tell in retrospect, right? How do you know you've actually at the peak until, quote, you're actually past the peak and you've got quite a number of days or weeks to show that, oh yeah, the downward trend is there. Therefore, actually the peak was, several weeks ago. So at this point, I wouldn't say that we've at the peak or past the peak, but we're certainly flattened the curve. The other point, as I think I mentioned earlier, is because we are at the national level, what the data we get is actually a composite of each of the provinces and territories. And so each of them have their own sort of epidemic curve. And so the situation in BC and how they progress through their epidemic curve would obviously be different from what might be still happening in Quebec. And obviously the experience in the territories up north and Atlantic provinces is completely different. So I think it's also something to keep in mind that what's happening in each of the provinces territories is a, quote, almost like an individual separate story, as opposed to just putting it all together at the national level.
Thank you. And we have a number of questions coming in. And so for people asking questions, some of them we're going to ask after we ask certain questions to Dr. Njoo for the flow of things, but they're really great questions coming in. And one of the questions that came in, and we also have it on our list. So CTV News, Health Canada has approved a test that can detect antibodies specific to COVID-19 in an individual's blood, allowing Canadian labs to take a significant step forward in understanding immunity against the disease. So Dr. Njoo, how will this test, the DiaSorin LIAISON, impact Canadians?
Okay, well, it won't have an immediate impact because obviously the focus right now, the testing that's in place by and large, is what we call molecular or PCR based. And that's really used for diagnosis purposes, right? So diagnostic purposes. So even then, people recognize, especially those in the sort of the laboratory world, that it all depends on the viral load, right? So even if you actually truly were infected, and we know the incubation period is up to 14 days, what they're saying is that hopefully if someone gets symptoms, the actual best time to test to get the best chance of getting a positive result is usually up to about sort of 2 days to 6 days post onset of symptoms. So that's something that we need to keep in mind. So that is still the main way we're diagnosing cases. What unfortunately has happened, it's interesting, is that I just know from conversations with colleagues in the provinces and territories is that in some places, let's say pick Toronto this time, is that let's say at least several weeks ago, it was a bit challenging to get a lab test should you actually have fallen ill. And a lot of family doctors, I think, rightfully set up, in terms of the priority, et cetera, you probably may need a test, but we're sort of stretched to our limit right now in terms of testing capacity. So the best thing for you to do is, if you're not feeling too badly, is just stay home and self-isolate, as opposed to, obviously, if there was a healthcare worker on the front line who fell ill with symptoms, it's more important, and you could probably appreciate, to make sure that person got tested right away and had sort of a test result. So as a result of that, a lot of people who may truly have had COVID-19 maybe several weeks ago and so on, went home, self-isolated, and so the actual management in terms of what needed to be done was correct. They stayed home, they didn't expose others and so on, and then probably recovered. But then the question still remains, wow, did they really have COVID-19? So that's one potential use in terms of almost like retrospectively going back to those individuals, and for almost, quote, retrospective diagnosis, use a serological test, which basically just tests your antibody response. And that also has a certain time, like after the onset of symptoms, obviously, as you can appreciate from your immunology courses, to then determine whether these individuals truly were infected with COVID-19. So putting that aside, the other big question that everyone around the world is asking is that, okay, if you truly were infected with COVID-19 and you developed antibodies, is that an actual marker for you now having immunity? And if you do have immunity, how long might that last for? So because we're also learning about the disease, we're also recognizing that there is a proportion of the population that might be infected but have very mild or what we call post-asymptomatic sort of clinical presentation, or some people even talk about very sort of almost asymptomatic presentation. And so one of the things that we're planning to do now in Canada, you might have heard on the news, is this fancy name called the Immunity Task Force. The Immunity Task Force is going to sort of lead a research effort across Canada, hoping to test a million or so people to get what we call a sort of a prevalence survey of who truly might have been affected. Because by doing that, you might actually get more information about sort of who might be at greatest risk of having been exposed, what might have been the outcomes. Certainly one of the hypotheses is that young people, by and large, may not have the same severe outcomes in terms of symptoms compared to older folks. And so if you did this type of survey, we might actually find a significant proportion of younger people who actually truly were infected, now have antibodies, and then were maybe totally unaware that they actually had COVID-19. So that's one part in terms of a prevalence survey to see how much of the population is actually infected or had previous COVID-19 infection. And then one of the other things that might be done is moving forward with studies to see on sort of on a serial basis how long, quote, the antibodies may persist in these individuals, and to what degree do they actually have immunity because of their antibody response. Because for a lot of other infections, you might correctly assume, or based on our experience, hey, if you have infection with this virus and you now have antibodies, you have a long-lasting immunity, even lifetime. But this is such a new virus, we're not making any assumptions about that. And we're also seeing experiences in other countries where, quote, there is a question about people getting reinfected. Even that one's a bit, I would say, not controversial, but the science is not clear on that. So sometimes these people, if they test positive after having had an earlier or initial COVID-19 infection, the question is it truly a reinfection, or is it just maybe a waning of symptoms and so on? And are we just maybe testing positive for remnants of the virus, which may persist long after the clinical presentation is passed? So there's still lots of unanswered questions in terms of the science, but that's some of the kind of research or actual public health related questions that this serologic test, now that it's been approved, are going to be used by researchers and others across Canada to try and answer some of those questions.
Thank you very much. And on a note on physical distancing, we know, and as you've mentioned, it's important, and that it's not without harms. And we're also hearing about a potential phased reopening plan for Canada. And we're wondering what that plan might look like. And then the question has come in that I think ties in with this from one of the medical students watching, is that how much do economic and external institutional factors, such as other countries' decisions to relax social distancing rules, influence Canada's federal decision to open up again? And in other words, there are many other stakeholders other than just from a public health perspective. How are those taken into account?
Wow, that's a good question. Let's unpack there. What I will say is that from a public health perspective, we recognize that, because of what we know about the virus, right? Physical distancing is one of the key things that needs to be done. Obviously, because of the 2-meter rule, and someone asked me a question, why that? And we all know that, based on studies, mostly from influenza, based on, people doing photography and so on. And if someone coughs or sneezes, and it's not covering their cough or sneeze, how far do the droplets, travel, et cetera. And so 2 meters is sort of the general sort of accepted sort of distance. Even now, there's further research being done as to how far those droplets can travel. So that's why we're putting that forward, and everyone gets that in terms of course, in addition to the hand washing and so on. So with that in place, certainly it's been shown to be effective, because certainly we know the case counts, et cetera, are going down. So what does it mean now moving forward? One of the things, though, to recognize, and people say about a federal decision, it's not a federal decision. Because provinces and territories are the one who actually have the responsibility for putting measures in place and taking them away for their respective populations, it all ends up on them. But because different provinces are in different places, the way they may slowly, quote, relax their measures and so on might differ in terms of the timing. So what we have agreed to, and this is actually something I think it's publicly facing, as they say, we actually had good discussions, and I think there's a document. If you go to the Canada.ca website, you might actually find a document. It looks at sort of the how provinces and territories may be lifting measures. So first of all, besides the core about maintaining those principles of public health like physical distancing, the other part also is that all provinces and territories need to be comfortable that their actual transmission is controlled. So I'll just use a current example. You can see it playing out in real time. That I think most people would agree that it's not controlled right now in, let's say, the island of Montreal, as opposed to maybe, let's say, Prince Edward Island or Yukon Territory. And so how those specific jurisdictions relax the measures, hopefully very slowly and prudently, will be different from what Montreal does. As to how that's done, I think one of the key things we look for in terms of public health is that there's a very, how you say, a sensitive surveillance system and good testing capacity to be able to detect if there is any uptick in terms of cases then occurring as a result of maybe the relaxing of public health measures, that any jurisdiction is able to quickly detect and, of course, do the traditional public health follow-up, management of the case, making sure they're isolated and treated properly, and then the contact tracing, making sure the contacts are put in quarantine, et cetera, and so on. So all that needs to be in place before you can actually keep going further. What's happened is that provinces are unfolding or are rolling out their plans with, as you can see, different speeds, but the principles are the same. So even in Quebec, that's one province, you can see that what they're doing for schools, et cetera, outside of Montreal is on a different sort of a schedule as opposed to what's happening in Montreal, where I think it's basically still in lockdown. And even now, I think the date keeps shifting because based on the daily case counts and so on, it certainly looks like there's still a lot of, quote, ongoing community transmission. So that's what I will say on that part. And then you're right, in terms of international experiences, we're in a sort of a good position in Canada. We can see what's happening in other countries and what their experience has been. And I think the two countries that come to mind right now are South Korea and Germany, which had, quote, their outbreak or epidemic curve before we did here in Canada. And they controlled it fairly successfully, I would say. And now they've been slowly relaxing their measures, and they've been also monitoring what's happening. And you can see quite interesting in South Korea that there was an uptick in cases, or at least one case that was linked to sort of this one individual seeing going to quite a number of nightclubs in Seoul. And I think to their credit, what they do there, it's not something we normally do here. It's not maybe part of our normal thinking and culture. I think all of the nightclub sort of attendees were required to sort of sign a register. So in that case, it was easier in some ways for public health authorities to be able to track down all of the contacts of this case and do the contact management. And I think they've at least temporarily closed down the nightclubs in Seoul in terms of trying to get a grip on that specific outbreak. And the same thing in Germany by looking at sort of the number of cases and seeing where this so-called R0 or sort of a real-time transmission is. They were below 1, which is, of course, what you want to slowly have the outbreak die out, as opposed to being above 1, where obviously one person is transmitting to more than one person. Right now, they're hovering about that that level of 1, and therefore I think they're looking at what they may need to do to adjust their public health measures. So based on what they're doing and their experience, they'll help guide us in terms of what individual provinces and territories would be doing here in Canada.
Thank you, Dr. Njoo. And you mentioned South Korea, and there's actually a question that asks, and I think you mentioned a reason why South Korea has done a reasonably good job at handling the outbreak. And the question is why, what were the barriers in Canada that prevented us from handling the outbreak as quickly as those countries?
Well, there's lots of reasons as well. And I think one of the things that I think South Korea was able to do is that they learned also from previous outbreaks. They did have an outbreak of even MERS-CoV, if people will recall that, and it caused quite a disruption in terms of the healthcare system and so on, and society there. And so they learned from that. What I would say is that they were very quickly able to establish a very good sort of a very intensive testing regime, if we can call it that, in terms of getting a lot of people tested. Here in Canada, I think we started off well. it was tricky because initially the sort of the gold standard test we had was in the National Microbiology Laboratory, which is part of our agency, and all suspect cases had to have their test results sent there. And then slowly there was what we call a technology transfer in terms of making sure that there was quality assurance and that the provincial labs were able to do their own confirmatory testing without having to send a sample to Winnipeg. So that unfolded over time. I wouldn't say that's a reason we did or didn't do well. It's just recognizing that they were very intensive in South Korea in terms of, I would call it the testing and contact tracing. But here then I think is one of the key issues that even now we're starting to grapple with in Canada. I would say that many countries in Asia, if I can characterize it, have more of what I would call a collectivist sort of a culture in which, you know, even though that there are also many of these countries like South Korea are democratic societies, like here we have in Canada, I would say that in general, without, you know, stereotyping, they also have more of a understanding and sort of a group or a community, a sort of perspective where if the government or someone says, hey, you need to do something, everyone recognizes that they have a responsibility role to do that. So I think there's more of acceptance of that compared to maybe, quote, more Western societies. And I would say even in Canada, there's probably, as you can appreciate, a difference between how we may view government and how we sort of go along with guidance and regulations as compared to even, quote, down south, our neighbors in the United States, where they might have more of what I might call an individualistic sort of approach to how people deal with their day-to-day lives. So that's one thing. And you can see how that also translates to what they were able to do in South Korea. I don't have all of the details, but certainly, as you can appreciate, use of technology in terms of contact tracing apps. We're having those discussions here in Canada now, individual provinces as well as the federal government, in terms of how that could be useful, in addition to what we call the shoe leather epidemiology, you know, actual people calling up and, you know, phoning and getting detailed histories, et cetera, and so on. People I think can appreciate how, you know, smart apps on your smartphone can help for contact tracing, also, you know, tracking people, you know, even I think there's with Bluetooth technology, if someone is close to someone else who might have been in contact or had a, you know, a diagnosis of COVID-19, you might get a signal or whatever. But of course, there's a balance depending on how the data is captured, how it might be collected or not collected, if it's anonymized and so on. There's a balance between sort of the public health objectives and what may be in the realm of the possible technologically versus also the great value we have in Canada in terms of protecting people's privacy and confidentiality. And so I think in maybe some countries and so on, they're more willing and maybe in a general way to give that up for sort of the public health objectives. And that's a live conversations I would say that we're having in Canada right now based on the sort of our values and our culture here in Canada.
Thank you. And a question on we're wondering is a vaccine coming soon, and as well as an approved treatment for COVID-19? And what barriers will public health, do you think that public health will face regarding finding, producing, and implementing a vaccine are in place? And could you comment on whether there's a possibility of making this vaccine mandatory either to the general public or healthcare providers and essential service members?
Okay, now we get to the area of vaccine. So first of all, in terms of the actual development of the vaccine, I think researchers, you know, scientists around the world are working, I think, obviously in their own sort of context, but I think also there's been good international collaboration to develop, you know, something really which is for the greater global good. So I would say that sort of with a good intent and a good spirit of collaboration, scientists around the world are madly working to try to develop a good vaccine. Right now, there are a number of trials going on around the world. And even yesterday, I think here in Canada, there was a announcement in terms of even a collaboration between, quote, Chinese scientists and also here in Canada in terms of also looking at another, quote, candidate vaccine. Most experts, and this is, you know, something that's been said for at least a few weeks now, say that most optimistically in terms of, you know, from basic research to obviously going through all of the various stages for clinical trials to ensure safety, efficacy, effectiveness of a vaccine. It's anywhere, even as fast as we can work, in the neighborhood of 12 to 18 months. And that's just to get the sort of safe, sort of effective vaccine. And then the actual production, whatever platform that may be used, obviously for influenza vaccine, it's still primarily egg-based. Who knows for this this vaccine, for this virus, what that may be. The actual production, ramping it up, and then the distribution, to physicians, frontline healthcare providers, public health, etc. However it works in the different jurisdictions of Canada, that's another element. I would say that overall, the system in Canada, I would say is pretty good, because certainly we have the experience for our H1N1 we had back in 2009. So once they developed the vaccine, in terms of rolling it out, or at least offering it and making it accessible to the general Canadian population, is pretty good. So I would say that I don't see any major barriers in terms of actually, once the vaccine is developed and produced in a mass quantity, that we can get it, quote, into the system so that it's available to actually administer to people. But one of the issues, obviously, that even before COVID-19 existed is the whole sort of, I guess, the anti-vaccination, I would call it, activists and so on, and sort of the misinformation, et cetera, that is, obviously spread in many different ways, and especially with the advent of, I would say, with the internet and social media. That is a real challenge now for, I think, all of us in public health, medicine, and science. All of the misinformation out there, and I just think from an anthropological point of view, I find it fascinating where someone may believe more sort of the celebrity wife of a famous athlete in terms of what they may say about holistic medicine and vaccines or whatever, as opposed to the actual scientists and doctors and people who have spent their whole careers with an actual education and experience with vaccines. But that's what we're up against. So I think we need to deal with that. Certainly before COVID-19 at the Public Health Agency of Canada, we have lots of folks looking at various studies, research, surveys, etc., to understand what shapes people's attitudes and so on, and how best to get information out there to combat the myths. I would say at the end of the day, and this I think is relevant for all of you as students, is that generally I would say that people's trust in government in Canada is pretty good, but they really, I think, really trust their doctors or their healthcare providers on the ground, their sort of trusted family doctor, to give them accurate information. So I think in many ways, the challenge for us, maybe for me or others, is to give the right tools and information so that the frontline healthcare providers are more, empowered to be having those good conversations with their patients and encourage them to get the vaccines that they need, especially the childhood vaccines. So to give you an example, it's a different story if, let's say, a patient had some maybe questions and they asked a physician who maybe wasn't as versed and just say, yeah, I think that's good. I think you probably might consider getting a vaccine, versus physicians got all the information at their fingertips and can say, oh, I think I'm glad you asked that question. First of all, I would recommend vaccination because A, B, C, and D, and I think we should probably schedule, if the timing's right, for you or your child to make sure you're up to date with your vaccine. So it's all about how I think also physicians present this kind of information to get hopefully better uptake by their patients, because they can answer any of the questions or concerns that their patients have. So that's all I'll say on that. And then the other part also is that I know maybe a bit of an advertisement for myself. One of the things they made me do, our communications folks, is that they saw from their studies that a lot of folks, especially the younger generations, don't look at traditional television to look at press conferences, et cetera, to get their information. They use a lot of platforms on the internet, like YouTube, et cetera. So there was actually a collaboration between the Government of Canada and YouTube to actually have a series of interviews done with sort of important Canadian YouTube influencers. So I actually ended up doing sort of 4 interviews with 4 major YouTube influencers, and hopefully it's been successful in terms of uptake. At least I looked at the number of views on the internet, and it's not pretty good actually in terms of hundreds of thousands. And that's another way we're trying to battle misinformation, and hopefully it's something else we can maybe do more of in the future. But I guess the last one is that I don't think in Canada we would ever get into a situation of making it mandatory, obligatory I think the closest we've gotten to for influenza, and this, I think I find it shocking that still there are doctors or nurses or other healthcare providers that are choosing, and I'm not sure what the rationale is for refusing to take, let's say, getting their annual flu shot. But I know a lot of hospitals, for example, then have policies saying that, okay, fine, we're never going to force you to take a vaccine against your, I guess, your beliefs or whatever. But then in the case of an outbreak, then certainly you will be excluded from work should there be an influenza outbreak and so on. So I can imagine a similar kind of thinking or approach maybe in the future for COVID-19.
And while we're still on the topic of treatments, we're hearing that in the States, Remdesivir is being said to become standard of care. And this is coming from a med student in the audience. Is this going to be the case in Canada as well? Do you think that the data is strong in favor of its use?
Interesting question. I'm going to be, neutral. What I would say is that lots of treatments, potential treatments are being examined around the world, and there are various clinical trials going on, including in Canada. We're actually part of sort of an international or WHO sort of a consortium called Solidarity with a whole bunch of different trials going on. For the Remdesivir, I would say that there was an article that's actually peer-reviewed that appeared in the Lancet. And it actually showed, if people want to look it up, that didn't seem to have any sort of a major positive or whatever effect in terms of outcomes and so on. So that was, in a sense, evidence saying that, well, it doesn't really seem to be that effective. Well, what's interesting, and I'll say, is that the U.S., what happened in the U.S. is that they had a press release in terms of touting, oh, there seem to be some promising results and so on. But I think the research community is out there, and I don't, maybe I've missed it because I haven't been able to follow on a daily basis. I'm not sure, I haven't quite seen yet the actual peer-reviewed study results in a journal yet. So I think we're all looking for that in terms of looking for those results to be also in the same way as that first study was published in the Lancet, appearing also in a peer-reviewed journal. In the absence of that, based on press releases and so on, I think they moved ahead in the US and they're going forward. But I would say that here in Canada, we would want to look at the sort of the study results for what's happened in the US. And certainly I think in Canada, we're also gearing up to also maybe have that looked at in Canada in terms of a properly conducted clinical trial. But I would say at this point, there's not that overwhelming or I say conclusive evidence in terms of this particular drug in terms of its effectiveness as treatment. I think further research still needs to be done.
Thank you. And something on the mind of medical students is that third-year medical student clerks will be entering the hospital soon, as well as fourth years entering residency. And apologies to McMaster, the years are a bit different there. But do you support this? And what safety considerations are there for medical students?
Well, I would say that to be all of the hopefully good standard infection prevention control measures which are in place in hospitals and now and so on, especially for, let's say, respiratory infections in general, especially with our annual flu season, should be always in play. And I think now it's just highlighted the importance of that because of this new virus, that causes COVID-19. Specifically, as we all know, the technical name is SARS-CoV-2. So I would say that medical students, as they enter into a sort of more of a clinical setting, they just need to follow the guidance that's sort of in place now, especially dealing with patients coming in but potentially infected with sort of COVID-19 infection. So I think it's just highlighted, and I think at least for the time being, if you look at what's happening in a hospital setting, it underscores the importance of having proper training, but also making sure that you keep following the practice. I think what many people miss when you see in the popular media these days is, oh yeah, everyone needs to get an N95 mask. I'm not sure if any of you have had a chance to actually use an N95 mask, but it's not all that comfortable to use, and certainly has to be fit tested, etc. And you have to also learn proper technique, as they call it, for donning and doffing, how you take on, take off, etc. the equipment. So all of those things, I think, in a good way, maybe if there's a silver lining, is that it's underscored the importance of how important it is to have proper protocols, but also to learn, be educated, and keep maintaining those types of protocols in the quote a clinical setting. So as you can see that in those settings where those protocols are followed, there's good oversight and sort of people monitoring that the infection rate is quite low, because obviously physicians being on the front line, obviously you folks as clerks and so on going into the healthcare setting, it'll be very important to make sure that you also have, I say, good practices in place, and you make that as part of your standard practice as you deal with patients.
Thank you, Dr. Njoo. And just a question before we go on to the future questions. We have some really good questions submitted to us, and I was wondering, for sake of time, if we go over 10, 15 minutes, is that impossible for you? I know you're incredibly busy.
No, actually, I think that's pretty good. I've done most. I mean, just check my calendar. You never know, something else might pop up here in terms of another meeting that someone's scheduled. But for now, no, I'm good. It's good. No problem.
Okay, thank you so much. A follow-up to sort of the question of medical students going back in, but just also the healthcare system, is that have public health officials discussed the secondary effects of COVID due to some hospital services or surgeries being shut down, or from people being afraid to visit their doctor, the hospital, etc.? And on that note, will the government be instructing the healthcare system to resume elective surgeries, for example?
Yeah, again, I think when you say government, it's not me, the federal government. It'll end up being provincial governments, because obviously they know their, quote, healthcare system best. One of the things I think all of us are recognizing is that there are a lot of what we call unintended consequences of dealing with the COVID-19, obviously, pandemic. And that's not just, quote, clinical in terms of medicine, let's say surgeries and so on. We also know that because of the lockdown, etc., people's mental health, let's say increases in, maybe substance abuse, alcohol, etc., and so on. That's all probably, quote, on the rise. And right now, I'm not sure if anyone's measuring that. Even sort of domestic violence, etc., and so on. So there are lots of things that people recognize are sort of falling by the wayside, or actually might be becoming a worse problem because of how we're having to manage and deal with COVID-19. And then if you look at, obviously, just clinical medicine, on the chronic disease side, we know that a lot of people have probably had their cancer treatments and other sort of medical care for other sort of non-communicable diseases affected because of COVID-19. And so there's also going to be, I think, an increased burden of illness as a result of that. And then I guess on the infectious disease side, one of my interests, I actually still do a TB clinic at the Ottawa Hospital here. I haven't been to clinic since beginning of January. So you can imagine, even for people with tuberculosis or HIV and so on, sort of the continuity of care for those patients are also, in a sense, not as ideal as they could be. I'm not sure. I haven't been to the hospital. Not sure how all that's working out. So that's there. And of course, as you just mentioned, things like elective surgery. So what I'm hearing and seeing is that the various provinces, for example, British Columbia, are starting to now address the problem of, quote, restarting elective surgeries. Also taking the example from other countries like Germany, because everything was cleared out, elective surgeries canceled, so they had sort of that surge capacity in the ICUs should there be a big influx of COVID-19 patients. I think credit to everyone in terms of how well we've managed up to now. We've flattened the curve, and certainly we haven't, quote, overloaded the hospital, healthcare system, ICUs, and so on. So now, I think the question is, to what degree do we have a bit of a buffer in terms of the ICUs? Should, as we relax measures, there might still be a bit of an influx of COVID-19 patients who need that specialized care, as opposed to restarting things like elective surgeries. So I think it'll depend again on each province and territory, and even at local level. What might happen in the city of Toronto and Ontario might be completely different from Hamilton or another part, or even here in Ottawa in the same province. So I think a lot of it will be based on local epidemiology and sort of what the local context is.
And do you anticipate a second surge of COVID-19 in the fall? And say medical schools, for example, do you anticipate that schools could close again, pull students out of the hospitals?
Yes, I would say that most experts around the world, ourselves included, say yes, definitely. The biggest or the most important wave is the one we're dealing with right now, this first wave, and hopefully we're going to get rid of and go on the downslope for this wave. But we certainly anticipate getting secondary, third, whatever number of waves, that the trick and challenge is to make sure that the waves are much smaller and manageable in terms of the demands on both public health and the healthcare system. So that all depends in terms of what we do in terms of what we might call relaxation of certain measures, and then how we're able to manage in terms of if there would be then a sort of the recurrence or a bit of an upswing in terms of the number of COVID-19 cases. In terms of, like you say, the not just medical schools, but all sort of education settings, be it high school and so on. That's to be determined, I think, at a local level. I think those discussions are ongoing. I wouldn't claim to be the expert in terms of how effective or what might be the balance between what we might call online learning versus what is, quote, done, quote, face-to-face in a classroom setting. I think people can appreciate there's pros and cons. People have different styles of learning, etc. Even going back, it's interesting for this online stuff. What's also been noted, I just seen some early sort of results or studies saying that it's a whole new way of practicing. So a lot of physicians are out in the field right now are doing virtual medicine. And at first you might think, oh, that's not really going to go well. But apparently what I've seen some early reviews is that many patients and physicians actually like that. Doing it, you don't necessarily have to have the patient come in. You can do at least an initial discussion, triage in terms of history, etc. And that might take care of a lot of the issues or questions patients have, recognizing, of course, that for many conditions, you actually need that sort of hands-on physical examination, and that it doesn't replace that, but certainly in terms of that initial contact or discussion or consult, I think virtual medicine has shown that it's been well accepted, and certainly I think I'll have a prominent place moving forward in the future.
Dr. Njoo, I have to ask, how do public health specialists like yourself balance providing information to the public without creating panic during a pandemic? And also, how do you balance that with public pressure and opinion and the leaders in elected office who may be pressuring as well?
Okay, I'm trying to think, okay, how do I, first of all, I think the most important thing is to be honest. I think people see through people if you're trying to hide things or you're too paternalistic and sort of, I know they don't understand or they don't need to know, I'll just give them this. So I think certainly for myself, I think Dr. Tam and all of the other public health officials going forward, it's about being truthful and honest with what you know and what you don't know with the general public. Having said that, I think it's also maybe it could be considered a learned skill or something you gain with experience, is how you translate, quote, the science in terms of how you call it, the knowledge transfer or translation in a way that is, how you say, digestible or easy to understand by the general public without, as they say, dumbing it down too much. So that, I think, is something that might be an actual, to be honest, I think is something we actually learn in the public health specialty in terms of what we call risk communication. So that's one thing in terms of general public. So that's something I've also learned over the years. I would say I'm probably better now than I was, 10, 15 years ago. And then again, same thing when you deal with, let's say, politicians and others who are decision makers who may not obviously have the same educational background. I think many of the people I deal with are ministers and so on. They're very bright people. They didn't get to where they are just, by not being successful in whatever field they were in before they entered politics. A lot of them are, I think, lawyers or successful business people, etc. So I think it's not a lack of intelligence, but you also need to be able to understand where they're coming from, their perspective, and be able to explain the science in a way that they can get it. And sometimes they also bring important, I think, perspectives to myself and others for us to reflect on. What is the interplay between sort of public health and the science and so on versus what they need to do? And so one of the things I've learned, and I also give this caveat to my classes when I do my teaching, is that in public health or science medicine, we always talk about, what we call evidence-based decision-making, right? You look at the results of clinical trials, the evidence, et cetera. And of course, you look at all that and say, well, this is what I should be doing for my patient because that's what the scientific evidence tells me I should do in terms of the best decision. So that's fine. But when we talk about policy in terms of what governments do, it's all about what we call evidence-informed decision-making. So the scientific evidence, the public health considerations are one aspect, but that we recognize that, you know, the way democracy works, that there are other considerations at play as well. So you need to respect and understand that. You give your best advice in terms of what could or should be done. You give the options. And then at the end of the day, they say the decision makers, the ministers, the politicians, they'll make hopefully the best decision based on what all the considerations are. And so we, especially in the federal government, we always talk about you have to give fearless advice and then loyal implementation in terms of what the final policy decision is.
That sounds like a great quote. And it's a good thing to mention right as we kind of go to the next question. And it's it's asking about lessons learned, but I think I want to preface it with something that someone in one of the medical students is bringing up, maybe as a combined question, is that people experiencing homelessness in Canada during this COVID-19 pandemic lack access to many things which most Canadians have come to expect, such as a home that allows them to follow stay-at-home directions, the ability to perform proper hand hygiene, adequate space to follow physical distancing orders. And so they were interested in knowing what has Public Health Agency of Canada been doing for people experiencing homelessness, and then sort of what lessons have been learned and what sort of steps would be taken in a future pandemic. And I think maybe it can be tied in with lessons learned in general from this pandemic as well.
Yeah, great question. I would say that obviously we could focus on, like you say, the homeless, but I would say that what this pandemic has revealed in sort of a good and bad ways is some of the vulnerabilities overall in our society. And so I would say that beyond the homeless, people in various, I would say, high-risk settings, congregate settings, we've obviously seen the results in terms of outbreaks and so on. So we've also noticed, besides outbreaks and what's happening in homeless shelters, obviously the long-term care facilities, how we deal with our seniors. I think, as I mentioned, even on media availability, it's a national tragedy. And I think, as our Minister of Health has said, it should be, quote, a national project afterwards, where with all levels of government and other sectors involved, we need to collectively figure out how we can do better in terms of how we treat and have our seniors taken care of in their later years. So that's another thing. And of course, another setting is correctional facilities, prisons and so on, very tight confined spaces have their own unique challenges. So that's also another area that we need to, I think, focus on, make sure that we're better prepared for, quote, lessons learned for next time. And then again, there's also a lot of these workplace settings where I think it's coming to light. You know, a lot of people might never have thought about, wow, you know, the steak I'm eating, where the heck did it come from and how is it processed? And now we're learning about what happens in some of these meat packing plants, et cetera, the tight quarters, how it's processed, the kind of conditions these workers are living, are working in, but also living in, because we're also learning that many of these workers are what we call temporary foreign workers, same as those who work in the agricultural sector, you know, picking our fruit, et cetera, and so on. So the whole food chain and lots of other things we take for granted in terms of what we finally have on our tables, in terms of what we eat and so on. We're now appreciating where it comes from and all of the quote essential workers that made it to be. So I think those are lots of things we need to look at. But I think in terms of the homeless shelter or situation, what we've done at the national level is that, along with our counterparts in the provinces and territories, we've developed guidance. So we've actually recognized some of the issues at play in terms of, I guess, say, the tight sort of settings in which these people are. It's more difficult to physically distance, the lack of hand sanitizers and so on. And I can just say that as we go along, there's been some innovative solutions. I'm aware that in some jurisdictions, obviously at the provincial territorial level, they've actually looked at getting additional sort of accommodation spaces to maybe house some of these individuals, so that there's a less crowding, if you can call it, in some of the shelters, and you follow what we might call alternative housing. So those are kind of some of the solutions that are being sort of developed very creatively. And I think as we move forward, not just in the homeless shelter, but in all those other settings, we need to figure out how we might improve things. So for example, I think in long-term care facilities, you can see that structurally that many of those facilities have maybe obviously 2, 3, 4 to a room. And so is that the best way of moving forward, or should there maybe now taking another look in terms of different ways to sort of house these individuals, so that should there be an outbreak, that it'll be easier to cohort the sick from the well, and so on and so forth. So lots of things to look at as we move forward.
Well, thank you, Dr. Njoo, for being able to sort of touch on all those topics too. It's much appreciated. And we have some sort of a few questions left for you, recognizing the time, but sort of a question that someone has submitted, and also something we wanted to ask. Now, in terms of medicine, you mentioned things like virtual medicine sort of taking off during the pandemic, but we're wondering what major long-term changes to healthcare, to medicine, to society do you anticipate following COVID-19? And one of the medical students also kind of wrote along the lines of, what major long-term effects do you suspect will follow such a drastic change in social norms? Like even with the implementation of a vaccine, will we continue to be encouraged to be 6 feet apart at all times? And would this be due to the goal of prevention, like second waves or new pandemics?
Wow. Okay, let me start. Maybe the easiest one in terms of medicine. You're right. There's always going to be a place that, doctors have to actually be in close proximity and actually, do physical examinations and so on. So I would say hopefully once COVID-19 is over and so on, I think some of the practices that hopefully will stay not just in the healthcare facility, but in the general public, is sort of the need for frequent hand washing, hand sanitizers, etc. I think there was a study done even before COVID-19, which showed that, sometimes doctors are among the worst in terms of washing their hands between seeing patients, right? So that was even before COVID-19. So now I think everyone's sensitized in terms of what good practices could or should be undertaken on a regular basis in the practice of medicine. So that's one thing. We already talked about virtual medicine. So I think that'll I think, grow, I think, in many respects. Telemedicine, especially in remote isolated communities, I think is already an important aspect of delivering healthcare, and I think that'll continue. So that's all I can think of in terms of quote medicine per se. I will say also that in the hospital, just like long-term care facilities, beyond sort of administrative and controls and protocols, there might be some engineering things that you might look at in the future in terms of how patients are put, how many to a room, etc. Maybe other physical barriers and so on might also be improved to prevent future outbreaks of respiratory infections like COVID-19. So that's it in terms of the practice of medicine. I would say more largely sort of at the business level. I think a lot of companies as well now are recognizing that they need to adapt to maybe quote the new normal, at least for COVID-19. Who knows moving forward. So I think in terms of teleworking, a lot of companies have realized that they can still be very productive with their staff working at home. You don't all need to be as physically in the same building and then hanging around the water cooler. So I think that's something that will continue, maybe even expand. I think as a result of that, certainly I think accessibility and having more sort of bandwidth for the internet will be important. I think people are taking it for granted now, but there are some places where I think internet access is still not what it could or should be. So that'll advance over time. And then in terms of the actual office spaces, I think some things will change maybe permanently in terms of the layout, in terms of how cubicles are designed or sort of the physical barriers and so on. So I'm not an engineer and I haven't thought that far ahead. I'll leave it for others, but those are the kind of things that I think will remain. Other than that, I would say that in terms of businesses, I don't know if this will become the norm or not. I think that remains to be seen. But the plexiglass now at cashier and checkouts, how grocery stores, etc., have the sort of their produce, etc., sort of displayed, and even now we see sort of one-way aisle. So will that be the future? And I don't know. Maybe for the time being, and we'll see how that gets adapted as we move forward in the future in terms of how businesses adapt. One of the things I've seen now, and who knows if that's going to be something long term, is that rather than having people go to the grocery store, I think there's been other innovations. Obviously, online shopping, but then people like to touch and feel their food or their produce or whatever before buying. And so I've seen that maybe on a pilot basis, I think I saw it in the news media where you now have trucks maybe going around with sort of a full display of the types of products that people may then stop and buy. So it's almost like that ice cream truck concept where, it goes around the neighborhood and stops at various places, and people come out and then look and buy what they need. So that's it for that service industry. I think the other part also in terms of future preparedness, one of the things we've also learned because of what's happened with PPE, et cetera, is that we've recognized the fragility of what we call the global supply chains and just-in-time, real-time sort of ordering and so on. So I think one of the things we'll look at in Canada, at least looking forward, is that to what degree is it practical to be self-sufficient? So in terms of, companies being able to adapt, like Bauer making hockey equipment to then face shields for healthcare workers and all those types of things, there might be a sort of a balance in terms of how our manufacturing capacity is able to deal with that. So that's another thing that I think we would look at. And then again, maybe going back to food and the agricultural sector, I think that people are appreciating the importance of everyone helping each other out, your community, helping support local businesses. So how much that might translate to sort of buying local produce and so on, and not relying always on having all your food sort of imported from all around the world. That might be something else that people would look at, and supporting local farmers, recognizing maybe it might end up being a bit more expensive, but at the end of the day, it's all good for everyone in the community, and so that's something else to look at. Other things I can see right now, I think the airline and tourist industry will have to make some major changes. I'm not sure what the future is for the cruise ship sort of tourist sector is, but I think they'll have to take a hard look at their business model and their clientele and see what it is that they maybe need to do adjust. Same with the airline industry. I don't know in terms of what you might do in the future, how to put the controls in place that people will feel safe and comfortable flying, but that's something that needs to be looked at. And then in terms of society, your question about whether we always need to keep this distance, I think, I don't know. Right now, I think we're always social beings. We need that interaction. I don't think people can always be 6 feet apart. Hopefully, people will be prepared to do that should there be another new novel, a virus and pandemic, and able to get into that sort of practice. But I don't know if that needs to be a long-term thing, if hopefully in the future we actually have a vaccine or good treatments for COVID-19. But one of the things that's actually an issue that's actually playing out right now in real time is the use of facial coverings or non-medical masks. Again, pointing to Asia and other cultures where I think it's been a practice and the norm where, it's accepted and it's sort of almost seen as a sort of respectful behavior where if someone is ill or you've got a cold and so on and you go in public, of course you're going to wear a face mask, not because you're really protecting yourselves, but you're protecting others from your cough and your respiratory droplets. And here now, you can see that it's becoming more of the norm. Many people are now putting it out in public. And if that's an added layer of protection in terms of all of the other measures we put in place, then it's something to think about and might become more of an accepted practice moving forward. So those are some early reflections. Hopefully it's maybe some others I might have missed, but other people can maybe come up with those.
I think that's incredibly comprehensive. And thank you to all the medical students who submitted questions. We've gotten to most of them, but we wanted to sort of have this final question put to you, Dr. Njoo, for the students in the audience. And I'll put it into two components. What would your advice be, and insight on the role of public health for medical students who are right now considering or interested in the field of public health and preventative medicine? And for those medical students who are more likely to enter clinical surgical practice, what should they take away from this pandemic on the role of public health within medicine?
Wow, okay. For those of you interested in public health, I think do your research or talk to people who are in public health. Now, I think you'll get a great appreciation of what they do. I've never regretted my sort of decision of getting into public health. I think, as I mentioned earlier, that if you have this sort of a certain altruistic, I guess, attitude, you might actually, on the good days, think that you could actually influence the health of more people at a population level than you might be able to do at an individual clinical level. Not to discount it, it's important. We always need those clinicians. I think in the future, especially for me, we'll need those geriatric medicine specialists as our population ages. I would say that public health, in terms of things like vaccination and things that will have a greater impact, advocating for a cleaner, safer environment and so on. You need those kind of specialists, let's say medicine, public health specialists, to be able to inform the decision makers, because those politicians and so on, even if they're well-meaning, if they don't have the right scientists or public health specialists making the case, being able to translate the science into things to be considered for policy, it'll never happen. So as I was mentioning earlier, for all of you, I would hope, take it for granted that the hepatitis B vaccination that you or maybe others got during their high school years or whatever in the school setting or however it was delivered wasn't in place when I was going through med school and so on. It was just only because of some unfortunate serious cases, deaths, and so on that people started thinking about it. And then you had to do the economic and other types of analyses to be able to present the case and make sort of the arguments so as to why it might be good to do that in terms of preventing a future burden of illness. And now there we have it. It's now in place. And more recently, in terms of HPV vaccine, et cetera, and so on, lots of good things I think are a result of public health specialists going forward. And of course, there's a lot of, I think, responsibility. If you look at the local medical offices of health and how they're able to influence their local communities in terms of, bylaws, food inspection, et cetera, and so on, but also in terms of what they're doing for outbreak management and control. Look at all of what's happening even in the city of Ottawa in terms of how they're so influential in terms of what both clinicians and the general public need to do in making sure that everyone's getting the right messages and doing the right thing. So I think there's a lot to be said for what public health can do. So the only other thing I'll add, maybe this is my plug, is that if you're interested, there's lots of things you can do at a local level. And I certainly enjoyed my experience working at the City of Toronto. It's a different, I think, a level when you work at the provincial level, where it's more, for the whole population of, let's say, of the given province. And then certainly when I entered the federal level, I really appreciate it because I also have quite an interest in international health. So the opportunities to actually interact and work out in the field internationally, working with colleagues at the World Health Organization. I've been there quite a number of times. Also going out in international missions. I was recently on a mission to help evaluate the TB program in Nepal. And I've also done other missions for TB, as well as looking at systems, how well countries are able to, detect cases and manage and so on in different sort of healthcare and public health systems. That's also a very, I would say, satisfying part of my work. And of course, if you ever think about working at the federal level, I think I would say right now, if you're not already have a sort of experience or have done French immersion, let's say for the Anglophone students, it really pays in Canada in public health to be able to communicate in both official languages. So certainly for myself, because of, I guess, my ability to be able to communicate in both official languages, I've had some great opportunities. For example, I was in Haiti post-earthquake, helping advise with the WHO in terms of doing needs assessment for what needed to be done post-earthquake in Haiti. And more recently, I was in Guinea for the Ebola outbreak in 2014 and 15. So it gives you an example of the kinds of opportunities and things you could do in your public health career. And then for the clinicians out there, go ahead. That we obviously need a clinical specialist. The only thing I would say is that public health and clinical medicine, they are closely integrated. And I think there needs to be, a healthy respect and understanding of what the important role each of them play. Because I would say that in some ways I straddle both those worlds because I still do some clinical medicine. And for me, it's interesting in TB. So here I am, I can work at sort of a high policy level in terms of advising colleagues in my immigration department here, what they could or should be doing in terms of screening for, let's say, migrants or immigrants coming to Canada, et cetera. And then I go to the TB clinic and I see those actual individuals who've been referred by the immigration department, newcomers to Canada, and seeing what works or doesn't work in terms of what then needs to be done at a clinical level. One of the most important things I would say is that there is a responsibility for all clinicians that if there is something that is of public health importance, I think in every province and territory, there's what we call mandatory reporting list, like TB is on that list, so that if you have a patient with tuberculosis, that automatically gets reported to public health. And then you need to cooperate and work with public health in terms of what they need to do in terms of contact tracing, etc. So I think that that's one of the things I would just want to press among you future clinicians, and also recognizing it works both ways. So public health might come to you if there's a new policy or an outbreak like COVID-19 in terms of what you could or should be doing and the information that they can feed to you, that you could help in terms of your practice and what you might also use to educate your patients, so that at the end of the day, it's a seamless system for the general public, and public health and the healthcare system are working closely together.
Well, Dr. Njoo, just wanted to say a massive thank you for your time, your role in the response to this pandemic. I'm sure that I speak for everyone here when I say that we are so appreciative of your work as a public health specialist and as Canada's Deputy Chief Public Health Officer. And thank you for your dedication to medical education and for reaching students across our 6 Ontario medical schools today. And also thank you to the Ontario medical students who tuned in. Please share this interesting knowledge that you have gained back with your colleagues at your respective schools. And I'll throw it over to Sophie.
I'm going to echo what Dave said. Thank you so much, Dr. Njoo, for your time and your work, and thank you everybody for tuning in. Just a reminder that we did film this session, so it will be available on the Aesculapian Society YouTube channel. We do not have as many subscribers as Peter McKinnon, unfortunately, Dr. Njoo, so we likely will not have as many views, but it will be available for all medical students. So if you enjoyed the session and you want to share it with your friends, please share the link, and we will make sure that all med slots have the link.
Okay, my pleasure.